Thank you very much, Rolando. I mean, it's a great pleasure to be here. And as Orlando was already saying, it's hard for us as a pediatric rheumatologist to come to general pediatricians and talk about what we are doing. You know, sometimes in the hospital, sorry, if you don't know what's going on, please call the pediatric rheumatologist. But this time, we are trying to talk about PFAPA, you know, which is the most common of the autoinflammatory syndromes that we know. These are my discussion of conflict of interest, and this will be the main outlines of the talk. First, introduction about recurrent fever and autoinflammatory diseases, Etiopathogenesis of PFAPA syndrome, clinical manifestation, diagnostic approach, treatment, outcomes, some take-home message. No? So where the study starts, the study usually starts. Okay, with fever, which is a widespread and misleading manifestation, is the primary manifestation of many different diseases seen in pediatrics. You already see it in your daily practice every day. And the differential diagnosis is very wide. I mean, infection, it could be recurrent or prolonged, it could be some autoimmunity disorders like lupus, vasculitis, some rare diseases like Behçet, immunodeficiency disorders, endocrine or metabolic diseases, neoplastic diseases, drug fever, factitious fever, dehydration. Sometimes we call it fever of unknown origin, or we can have autoinflammatory diseases. So how we face it? The truth is like story also start with parents arriving to the clinics. They say that the child always look ill. The mother said she lives in the pediatrician clinic. The grandmother says that the kid must have something, and the sister-in-law, which is starting to be dangerous, they must go to a good specialist. No, the pediatrician used to review the medical records once, twice, several times. Well, the kids have several fever episodes. Are these infections? Are they too much? If they are, what the pediatrician must do. No, that's what we face every day in our practice. But how we focus on it when there is a child with recurrent fever episodes? First question that we must ask is these frequent infections, are these normal or abnormal? How we can decide this? Are these then, which is quite risky, is this we are seeing or visiting a child with a possible primary immunodeficiency, or if not, we are in front of autoinflammatory disease. No? And this process is what we must consider when we are seeing these kids. Just to clarify, we talk about fever without source in front of a child with less than 1 week of fever, with studies according to age that doesn't identify a source. It's a little bit different of the definition in adults, where they require 2 weeks, but in children it's just 1 week. Fever of unknown origin, it's for more than 1 week. In adults, it's more than 2 weeks, and after the first line of medical study. And then we have this recurrent or periodic fever, there are 3 or more episodes in 6 months, at least 7 days apart. No? So that's when we are talking about a recurrent or periodic fever. No? Just to remind, it's not the topic of this session, which are the recommendation of the Jeffrey Mudoller Foundation as a warning signs to consider a possible immunodeficiency. No? What we must consider that we are in front of a child with a risk of primary immunodeficiency. And I found it very useful for the daily practice for primary care pediatricians, emergency rooms. So 4 or more new ear infections within 1 year, 2 or more serious sinus infections within 1 year, 2 or more months of antibiotic with little effect, 2 or more pneumonias within 1 year, failure of an infant to gain weight or growth normally, recurrent deep skin or organ abscesses, persistent rash in mouth or fungal infection on skin, need for intravenous antibiotics to clear infection, 2 or more deep-seated infections, including septicemia, or a family history of primary immunodeficiency. So these are the clues that Jeffrey Mudoller that supports primary immunodeficiency recommends to have in account. But if we are talking about primary immunodeficiencies, in fact, one of the groups of primary deficiencies is what we call now autoinflammatory disorders. So in this 2015 classification, we still have these autoinflammatory diseases as one of primary immunodeficiency disorders. No? So what are the autoinflammatory diseases? No? So these are clinical disorders marked by abnormal increase of inflammation, mediated predominantly by the cells and molecules of the innate immune system with a significant host predisposing. So summarizing, and I think it's one important concept of the last 20 years probably, no? We talk about autoimmunity as a defect of adaptive immune system, and we talk about autoinflammation as a defect of the innate immunity. And that implies that, for example, in adaptive immunity, we have a breakdown of mechanisms of cell tolerance. Usually we have aberrant B and T cell response, and could be some organ-specific antibodies. No? Example, for example, is lupus, which is a hallmark of this, or juvenile dermatomyositis, or scleroderma, or thyroid organ autoimmune diseases like hypothyroidism, etc. And then we have autoinflammation with a defect of innate immunity, where there are other cells that are mostly affected, are macrophages, neutrophils, where we have innate intercellular danger sensors, which we call inflammasomes, and where there is an excess of related cytokines. Recently, it was consensus proposal to define these autoinflammatory diseases as those clinical defects with dysregulation of the innate immune system that are characterized by recurrent or continuous inflammation. We say it's a different recurrent or continuous inflammation with elevated acute phase reactants and the lack of a primary pathogenic role of the adaptive immune system. No? So there are not autoantibody production. You will see that in the literature, if you search in PubMed, as it was done last year, there are a lot of references or a lot of papers talking about autoinflammatory. This is what is an example of the growing interest in this kind of diseases. No? And what we have known is that there is an spectrum from the primary immunodeficiencies to the autoinflammatory diseases. In one extreme, we will have we will have monogenic innate immune diseases with defects like APC or IPEX that are related to a monogenic defect with an immunodeficiency. And in the other extreme, we will have autoinflammatory diseases also due to a defect, which are the familiar Mediterranean fever, or cryopyrinopathies, syndrome CAPS, or hyper-IgD, or TRAPS, or others. No? And this growing world of autoinflammatory diseases is increasing every year because every year we are identifying new autoinflammatory genes, some of them purely autoinflammatory, other with a mixture of autoinflammation and infection or immunodeficiencies. So these are what we call the monogenic genes, but we have seen that, as usual in medicine, things are not so simple. We were initially identifying autoinflammatory disease as those due to a defect of a single gene. Currently, we consider that autoinflammation is wider, and we know that some diseases could be considered also autoinflammatory diseases. So in an spectrum from clear primary immunodeficiencies due to a monogenic gene to a clear primary autoinflammatory diseases due to autoinflammation immunodeficiency gene, we have this mixture of diseases like, for example, inflammatory bowel disease or Behçet, and also the disease that we are going to talk about now, which is PFAPA. So we have these monogenic autoinflammatory diseases, the related recurrent fevers, the most typical, and some of you coming from countries like Armenia, Turkey, Israel. You probably know it better. It's familial Mediterranean fever. Others like hyper-IgD or mevalonate kinase deficiency or syndrome TRAPS. The cryopyrinopathies, which implies 3 different diseases, recurrent cold fever, or Mackerwell syndrome, or syndrome Zinka, and other which are more rare, like Blau syndrome, DITRA, etc. And then this polygenic complex autoinflammatory disease, where we have systemic juvenile idiopathic arthritis, that for a long time was called still disease, that in fact our colleagues from adulthood, they call still adult onset disease. And other diseases like chronic recurrent osteomyelitis, Behçet disease, or PFAPA syndrome. No? So PFAPA is considered a polygenic complex autoinflammatory disease, not due to a single defect, comparing with the other monogenic autoinflammatory diseases. No? So in this polygenic, we have also a dysregulation of the innate immune response with increased levels of inflammatory cytokines and mediators, with no Mendelian inheritance, no known causative mutations, at least till now we know, and with an interplay of genetic and environmental factors. The name is quite simple. It's due to the acronym periodic fever, Aphthous Stomatitis, Pharyngitis, and cervical Adenitis. It is the most common recurrent fever syndrome in childhood. It was described in 1987 by Marshall, who published 12 patients. The name was proposed in 1989. And we calculate there is an incidence of 23 every 100,000 children younger than 5 years old, which is quite common comparing with other diseases. No? So which is the etiopathogenesis? What we know till now about this? There is not appear to be a cluster in particular ethnic group, so it has been described in population, in the States, in Europe, in different countries, also in Asia, South America, Africa. So it's not that we can cluster or identify a group of a population or ethnic group. The issue of involvement of other family members, as we don't have clear criteria or we don't have a golden standard to the diagnosis, it's difficult. That the studies are ranging from 10 to 80% of patients with different family members that explain recurrent fever picture. So it can happen. If that's important when we are doing the medical history of these patients, is to ask parents, and sometimes we are lucky that can come in the grandparents also ask them if there are other family members affected. Well, there have been several studies to try to figure if there is a link. Not only the usual studies of autoinflammatory diseases, but also whole exome sequencing. And it looks like there is an autosomal inheritance pattern with an estimated prevalence factor of 50%. That doesn't mean that there is a single gene, but probably there is a predisposition due to different genes in these families. No? For example, in this series, 23% of patients has at least one family member with symptoms that were suggestive of FAPA. So that suggests an autosomal dominant inheritance pattern. But sometimes individuals inside of these families didn't show the strong concordance in terms of episode characteristics. No, they are not the same in each of the family members, which suggests that this clinical picture is moderated by other factors, probably environmental factors, that influence the phenotypic manifestations of the disease. Moreover, some of these family members with recurrent pharyngitis or recurrent Aphthous ulcers, which is one of the symptoms, one of the hallmarks of this disease, do not meet the FAPA typical diagnostic criteria. So the question that arises if there are reduced penetrance phenotypes of FAPA syndrome. As I told before, there have been tried several genomic analyses, for example, trying to look for variants in the gene for marenostrin, which is the gene for familial Mediterranean fever. And we know that some of the patients that present with FAPA syndrome that also have mutations for the MIF gene have a more resistant to conventional treatment, but they have better response to colchicine. And we will talk about the treatment later. In another study with 100 Israeli patients with PFAPA syndrome, they found that they were heterozygous for common MEF mutations like MC400V or E148Q. So these patients have attenuated form of the disease with shorter episodes, less regularly in timing, which is another characteristic of PFAPA, less likely to have associated Aphthous Stomatitis. And again, it's considered that some of these heterozygous mutations, these patients that already have what we call PFAPA, with these mutations have some influence in the clinical phenotype of this disease. Other gene that has been studied is the study for NLRP3 gene, which is the gene that identifies the what we call cryopyrinopathies, a group of autoinflammatory diseases with a wide range of severity, from mild forms, which are just characterized by cutaneous lesions, urticaria, sometimes with arthralgia or arthritis, to very severe forms of disease with CNS involvement, endocrinal hypertension, severe joint affections, mental delay, etc. What we have found is that 15 in this paper, it's shown that 15 or 57% of patients, 57 patients presented some mutation for this gene. So a lot more common than in general population. In another study, 48 unrelated PFAPA patients, they found that 14 of them have a mutation in the gene CARD8, and that's comparing with health population of 3-point healthy controls. No? And these patients have a slightly different clinical picture. So those patients with the CARD8 mutation have more Aphthous than in those patients without, and well, it's clinically significant. So which is important CARD? I mean, I would like to introduce the concept of inflammasome. There are not like receptors. These are cytoplasmic proteins with a variety of functions in the regulation of inflammatory and apoptotic response. This is not an organelle inside of the cell. It's not like the nucleus or the mitochondria. It's like a group of proteins that assemble and have this function and then disassemble. And this inflammasome, there are several of them, depending on the proteins that are involved. They are like LRP1, LRP3, or Epstein melanoma 2. This group of proteins that assemble, there is one which is CARD. This is the one I was talking before, and that's important because this CARD is good. It's common also in LRP3. So this defect influences in the inflammasome. And what does it mean? Well, if we have a defect in this protein CARD8 that interacts with the NLRP3 inflammasome, inhibits the ability to activate caspase-1. And caspase-1 is necessary to cleave the pro-inflammatory anti-IL-1 to active form anti-IL-1. And IL-1 is a cytokine clearly related with inflammatory response and without inflammation. So with these patients with CARD8 mutations were probably more prone to have Aphthous ulcers and symptoms between flares due to this activation, due to this defect of the NLRP3 inflammasome that frees more IL-1 that is expected in a normal patient, in a normal subject. But we have other information about etiopathogenesis. There have been studies about biomarkers during febrile episodes that show increments of monocytes and neutrophils, and that's important if you remember what we were talking about innate response versus adaptive response. So it suggests there is an innate effect. We have this increment of caspase, which is the one who cleaves the IL-1, and we have, of course, increments of IL-1 beta comparing with healthy children. What again points to autoinflammatory response due to an innate defect or polygenic innate defects. So monocytes of FAPA patients have dysregulation in discretion of IL-1, and some therapeutic approach has been done based on this information. And well, it's hypothesized that the etiology of this disease could be related to alterations in the activation of the inflammasome. So we have this regularly of febrile seizures with good response to glucocorticoids with a suspected immune disturbance, with some feature of innate immunity, like the inflammatory cytokines that are increased, the genes related to the function of the inflammasome, the increase of monocytes and neutrophil numbers, and we have this some adaptive immunity response, like lymphopenia, that we can also have in these patients. But we know that this is a regular disease that usually happens every 3, 4, 5 weeks, and that we will talk about it later, that some of these patients respond to tonsillectomy. We wonder why it happens. Why these patients respond to tonsillectomy. There have been some studies about tonsil immunology and microbiome. Well, there is a curative role of the tonsillectomy in FAPA in a lot of these patients that have focused attention to try to understand the pathophysiology which is behind of tonsils, like possible triggers of these episodes. So there are some studies trying to compare tonsils from patients with other tonsils of healthy individuals, and they take patients with sleep apnea due to tonsil hypertrophy. So suppose that there are not FAPA syndrome, and try to analyze these different tonsils. They found lower percentage of B cell, higher percentage of CD8 T lymphocytes, fewer CD4 positive T cells, and other characteristics with high expression of the inhibitory molecule PD-1 or elevated T cell chemokines. Other work show that FAPA tonsils express less IL-4 than those patients with hypertrophic tonsils. And if we talk about the microbiome, and this is a fascinating world that we are just going into and we don't understand for sure, what is seen is that through next generation sequencing studies, studies from microbiota from tonsils, comparing in this paper 30 FAPA patients with 24 controls, there are no differences in microbial populations by the principal component analysis. So we really didn't find causative agent that we could identify in these tonsils, which was already something that we suspected, because we were not looking for a single agent that caused this disease. Which single agent, infectious agent, can cause a periodic fever or periodic infection every just 4 weeks in a clockwise? Well, one thing that we have seen with the microbiome study is something different and probably more relevant, is that in FAPA patients, we lost this multiple field of microbiome. I will try to explain. When we have, one of the things that experts in microbiome say is that a healthy individual have a variety of flora living with him. To have just a few or reduction of this flora, it's not so healthy that to have, instead of having, 10 or 20. And we have in these FAPA patients, this a reduction of this main genera or main group. So these FAPA patients present some characteristics that we think it's make it the patients prone to have these flares of fever. No? The lack or the loss of this variety in the microbiome could predispose to have these fever episodes. So FAPA is not an infectious disease, although through an assessment of the virome and fungi have not been conducted. We have been focusing more on bacteremia. But it remains unclear if this tonsil microbiome plays a role in stimulating the disease or in helping to express some of the symptoms. No? So there is not a triggering agent probably. Infection transient in tonsil and crypts, well, the disease stability, the self-limitation, the absence of elevation of procalcitonin, the efficacy of glucocorticosteroids, or no temporal geographic grouping, it's against it. And the tonsillar microbiotic could suggest, as we will say, an environmental factors that justify family aggregation. So we have family aggregation, we have history of affected twins, we have probably some families with autosomal dominant inheritance pattern, but no monogenic, and with some environmental factors that give rise to the phenotypes and different penetrants. We have these variants in some of the autoinflammatory genes and variants in the related gene to the inflammation. That's what we already know. So FAPA is probably a complex disease with a polygenic inheritance. Inflammation could have a role in this disease. And we have probably a paper for these tonsils that we are just trying to know. These tonsils can have a unique microbiome composition. There are some work that has been done trying to relate to the etiopathogenesis of FAPA syndrome. For example, if there is work related to vitamin D, but have not been concluded. There are some works that say that there is significant correlation between FAPA and vitamin deficiency, as has been described in other rheumatic diseases. Other work says that it's an inverse correlation. And the last one, just published this year, suggests that there is a strong correlation between FAPA and vitamin D insufficiency. And what suggests the author is that hypovenosis D can be a significant risk factor for episode recurrence. Which are the clinical manifestations of FAPA syndrome? Well, the clinical the criteria were regularly recurrent fevers with an early onset, less than 5 years of age, with symptoms in absence of upper respiratory tract infection with at least one of the following: Aphthous Stomatitis, cervical Adenitis, or Pharyngitis, with exclusion of cyclic neutropenia, with patients that are completely asymptomatic in interval between episodes, and with normal growth at development. So patients between 1 and 5 with a normal growth, with episodes every 3 to 8 weeks, usually 4 or 5 weeks clockwise, and with high fever, pharyngitis, aphthous, and lymphadenopathies. No? But there can be other symptoms like headache, constitutional symptoms, osteoarticular symptoms, digestive symptoms, or exanthema. This is a typical picture of a patient with cryptic tonsillitis during an episode of fever, and with usually negative culture for strep. Patients present with moderate leukocytosis, with neutrophilia, monocytosis, as we told before, with lymphopenia, eosinopenia, with an increase in acute phase reactants, ESR and CRP. Procalcitonin does not rise in proportion to the rest of the acute phase reactant, and some patients present hyper-IgD, which sometimes mislead to when we are considering other autoinflammatory diseases. What is important, as much as this, is that these patients present a normal blood count and acute phase reactant intercrisis. No? And that's the reason we try to have at least one control of these patients during fever episodes and another between the episodes to rule out other autoinflammatory disease with a more permanent course. In 2014 was published, which is the bigger cohort of patients with FAPA syndrome in a multicentric study, international, 15 centers with 301 patients, and we found that cutaneous rash was present only in 13%. Most common, of course, was fever with 100%, pharyngoamygdalitis in 90%, lymphadenopathies in 70, almost 80%, and others like after 60%, or some patients with digestive symptoms. So you see that not all the patients present always the same characteristics. In our cohort, we have already 85 patients. We saw a proportion, it's slightly more for female, but only 51 versus 48 patients. Age of onset was around 27 months, with age of resolution, which is important also, around 7 years, between 6 and 8 usually. The length of the disease in years when we recorded this was about 4.8 years. That's important when parents ask us about which will be the outcome of these patients, and with a family history positive in 24% of the patients, so quite similar at what has been already reported. Clinical manifestations in our cohort were 100 of patients with fever, 85 with pharyngitis, 70% with adenomegalis, and 60% with Aphthous. So you see that Aphthous probably is the less reported, also because probably doctors or families are not checking in the kid with fever if they have Aphthous or not. So it can be a bias. No? Other manifestations with abdominal pain or cephalia or arthralgia. And the fever pattern usually it's about 4.3 days with a maximum of temperature. It's a process that has a high peak in fever till almost 40 degrees. Periodicity is around 4-6 weeks, but around 40% of the patients present a shorter period than 4 weeks, so around 3.5 weeks. Glucocorticoid response to treatment in our cohort was positive in 90% of the patients. And some of them require a second dose of steroids, and 24 of our patients went to tonsillectomy with a good response in 70%. We tried colchicine in less than 6% of patients. No? These were our cohort. I present at the beginning which are the classical criteria, but sometimes we find that these criteria are too strict that don't permit us to identify all the patients with this periodic or benign fevers, as Dr. Chimas was saying at the beginning. So there have been different tries to arrive at a better definition for these patients. This was the work of a group of colleagues that tried to identify and meet several years ago in March in Switzerland, and tried to identify or propose a new classification criteria. We decided to say periodic fever for at least 6 months with a daily fever at least 30.8, because we find these patients have higher peak fever, for 2 to 7 days, and at least 5 regularly recurrent fever episodes with maximum of 2 months intervals between them. Pharyngitis, cervical adenitis, oral Aphthous, at least 1, and it's common with the previous criteria, in every episode, and at least 2 out of 3 in the majority of episodes. Exclusions of other criteria, of other causes, and we not only consider cyclic neutropenia, as since it was proposed in 1999, a lot of other autoinflammatory diseases, as I have been telling you at the beginning, have been identified. So we include also other autoinflammatory diseases or immunodeficiency. Disease onset before the age of 6 years with a full recovery between episodes and with a normal linear growth. And this was finally published in 2018. But this year, in August, was also published, which is a huge effort of the pediatric rheumatology community, which are the classification criteria for autoinflammatory recurrent fevers inside of a more wide group, trying to identify clinical and genetic criteria for autoinflammatory diseases. We focus also in PFAPA, and the proposal is that at least 7 out of 8, we need the presence of pharyngeal tonsillitis, duration of episodes between 3 and 6 days, cervical lymphadenopathies, periodicity, and the absence of diarrhea, chest pain, skin rash, and arthritis. If we present 7 out of these 8 criteria, we have a sensitivity of 0.97, specificity of 0.93, and accuracy of 0.99, which is quite hard in the cohorts that we are tested. In fact, it was presented as an abstract 2 years ago in one of our pediatric rheumatology meetings, comparing this previous new FAPA criteria with this modified Marshall criteria. We found that the under curve is a lot better, with better sensitivity, specificity, accuracy. So probably we are defining better to identify these patients with FAPA syndrome. what is our diagnostic approach? Well, as usual in medicine, I think it's a hallmark that we have present. There are many patients with a fever at the clinic, and that's what we're trying to say, but only a few with autoinflammatory diseases. And the difficulty of diagnosis is what is not known is not diagnosed. So already we as pediatricians are interested in FAPA syndrome, so probably that will not happen as no. Which are the role of the pediatrician in recognizing autoinflammation? Well, it's important we can improve quality of life of these patients. We can avoid unnecessary and unfruitful examinations. One of these patients have the diagnostic of autoinflammatory syndrome or FAPA syndromes. We avoid that every time they arrive into the emergency room, we start to doing blood tests or other expensive treatments or looking for other diseases each time that they are going to seek a better diagnosis because they are not happy with them. It's important through an accurate follow-up to avoid permanent complications like some of autoinflammatory diseases. It's not the case of FAPA syndrome for sure, but other autoinflammatory diseases can cause amyloidosis, hypocausias. In those that have a genetic cause, it's important to identify and to consider new treatments. So we have in front of a patient with fever to make a differential diagnosis, consider immunodeficiencies like cyclic neutropenia, consider infectious disease like recurrent infections or pharyngotonsillitis, considering inflammatory diseases like Behçet's disease or inflammatory bowel disease that can present also with fever, tumor pathology, autoinflammatory syndromes, and the most common confounded that can be misled with FAPA syndrome or hyper-IgD syndrome, sometimes FMF, or a new identified haplosubstantia of 820, which is an autoinflammatory disease with recurrent Aphthous. And well, which is the approach we can have, no? How we clinically can consider in front of a patient with with an autoinflammatory syndrome. The first thing that we can ask after a family story if there is a periodicity. If we are in front of a patient with a clockwise picture with fever, after lymphadenopathies, it's a strong possibility that we have FAPA syndrome. Then, depending on the days of the duration of the fever, we can consider other diagnosis. Less than around 2-3 days, continuous fever with urticarial lesions, we can consider a cryopyelonopathy. With patients with less than 72 hours, with sometimes monoarthritis or recipient-like lesions, we can consider FMF. In patients with less than 7 days, with abdominal symptom of a predominant of abdominal symptoms, with age of onset less than 1 year, we can consider hyper-IgD syndrome. And this is probably the autoinflammatory disease that most common can be misled with FAPA syndrome, and with patients with more prolonged fever of more than 7 days, not the use of a patient, sometimes with cutaneous lesion, with pain due to fasciitis, we can consider TRAPS syndrome. Several years ago, almost 11, the group of Printo in Italy suggested a score to identify patients with periodic fever that need genetic analysis. This was focused only in 3 different diseases, FMF, TRAPS, and HITS. And just considering some of the variables you can approach if the risk of having monogenic autoinflammatory diseases was high or no. And with this approach, they can differentiate also between those patients with suspected FAPA or those patients that could have another of the monogenic autoinflammatory diseases, which are talking just about the main ones. So when we approach to a patient with periodic fever, we must know the age of onset, and we see that this is one of the criteria for that has been proposed for FAPA syndrome. The duration of the periodicity of episodes. I mean, these episodes are the same during all the year, or do they have a predominance during the winter time with a free interval during the summer? So probably we are more in front of a viral infection and not in front of a recurrent autoinflammatory disease. We must know also if there are a concurrent illness in contact, so if there are children in the home and daycare or school with other similar clinical picture, which are the characteristics of the episodes, if they are identical, those that every time are the same, if they have an abrupt start or if they have a predictable course. If there are triggers of these episodes, if we have a family history or not, and which are the response to different treatment, non-steroidal anti-inflammatory drugs, colchicine, glucocorticoids, etc. This is the information we must record. No? We must examine other clinical parameters, like if there is a rash, abdominal pain, serositis, lymphadenopathy, if the patient presents arthralgia or arthritis, if they have conjunctivitis or periorbital edema. We must exclude other disorders in different diagnoses. And what I suggest, and it's quite important, is to ask families to have a calendar of symptoms, to record them, because if not, it's very difficult when they come to the clinics to ask about periodicity, duration of fever, because also the kid is quite often affected, they forget it. So it's simple, it's economic, but just to ask them to have a calendar of symptoms or give them a sheet with a table will help. Because if you ask them to collect the data, probably they will forget, and they will not come with this to the clinics, or just before they are going into the clinics, they will write in a piece of paper or be in the rear of a receipt, the summary. But if you give them this piece of with a table, probably they will record or better, or at least you increase your odds that they will record it better. Which is the treatment of these patients with FAPA? Well, there is no treatment of choice on clinical, good randomized clinical trials for FAPA syndrome, but the two main treatments that have been considered are tonsillectomy and glucocorticoids. Glucocorticoids given as prednisone, 0.5 or to 2 milligrams per kilo in a single dose at the beginning of the fever flare, is effective in the control of fever and pharyngotonsillitis in 24 hours, but do not prevent the appearance of new outbreaks. And what has been described is that steroids sometimes, when you give steroids, you have a good response, but you see a shorten of the interval between the different crises. Well, it's the good thing, and it's important to know because family are scared of steroids, and sometimes doctors too. It is a single dose or two doses every 2 weeks or every 4 weeks. Doesn't imply a risk for side effects. Neither if you consider a single dose in a patient with a severe risk infection, you are not going to change the prognosis of this patient just for a single dose of steroids. You are not under lowering her defenses due to a single dose of steroids. So don't be afraid of a trial with steroids if you consider a patient could have a FAPA syndrome. The question is, other autoinflammatory diseases can have a response to steroids, but that's another issue. Regarding tonsillectomy, sometimes only tonsillectomy, other with adenoidectomy, we know it's effective in the total or partial resolution of outbreaks, but it's not risk-free, it's a surgery, so it of course implies some anesthesia procedures, it's a surgery, patient must be admitted at least for the day, so it's something that must be pay attention, we only recommend in selected cases and in agreement with the family. There are some studies that show that it's more effective than cimetidine and antibiotics, and compared with corticosteroids do not show a statistically significant difference. No? The results about this tonsillectomy, usually in this series published this year, around analyzing different published series, is going between 78.6 to 90%, so a quite good response. And in the unique, there are two randomized trials. One of them show resolution of febrile episodes in 12 out of 19 children with adenoidectomy and tonsillectomy. I don't include the other study because the criteria were not defined, so the science behind it was not so clear. So there are no clinical benefits adding adenectomy to tonsillectomy till we know. I think we lack of more studies to clarify this issue. Other drugs that have been used in the past, cimetidine, because it's coming back to the beginning of the description of the disease. But there is a weak evidence for both pediatrics and adult patients, and there are also PFAPA patients in adulthood, with doses that have been tried from 300 milligrams a day for children to mid 20 milligrams kilo. Usually, and this is consistent in different publications, a quarter of these patients could have a response to cimetidine. We didn't review in our series because in our country cimetidine is not possible for a long time to buy it, so we don't have personal experience about cimetidine. But what has been published is that a quarter of patients could respond to cimetidine. Other drug that has been used is colchicine. We know that in some patients, the intensity and frequency of outbreaks decreases, and it's mostly related with those patients that I described at the beginning that could have some heterozygosis variants for the MEF gene. And well, these patients with very frequent episodes with corticosteroid that you maybe have done these genetic studies and you have this variant, you can consider to a trial of colchicine, and that's our experience in around 6% of these patients. And with at least an improvement or with a widener of the episodes that sometimes is helpful for the families. Instead of having your kids every 2 or 3 weeks with fever, one every 2 months helps a lot. And which is more new, and I think it's just under study, it's not that we can consider it for our daily practice, is this anti-IL-1 drugs. As I told you at the beginning, talking about etiopathogenesis, there is an innate immunity effect, and that implies also the increase of IL-1. That's the reason because I was trying to explain you which are the hypotheses behind the etiopathogenesis of this disease. So if we consider there are this increase of IL-1 and we have drugs that can block this IL-1 cytokine that is pro-inflammatory, why are not we giving these drugs? No? And this work shows how we have a great response giving anakinra, which is given daily to these patients with a decrease of the cell rate, with a decrease of the fever episodes. The question is not a very risk drug, which also is expensive for patients that have a benign course of the disease. Other drugs have been tried also in another patient, has been published with another anti-IL-1, which is canakinumab, which it's a lot insanely expensive, and I don't think that that could arrive to daily practice. But it's important to show that there is a role for the anti-IL-1 blockade on these patients. Which is the outcomes of these patients? The most important is that this is a study published last year. The well-being of PFAPA patients is poor, with a lot of impact in psychosocial, functional, and increased fatigue. And not only in the patients, if we consider the family as pediatricians as a whole, this family with children with frequent fever for 1, 2, 4, 5 days every 3 weeks, it's exhausting, it's devastating for them. No? So the quality of life of these patients with theoretically a benign disease is poor comparing with others like FMF, which are more will be long life disease. No? There was also presented in one of our meetings of the Pediatric Rheumatology Society 2 years ago, a pilot study from colleagues from Norway to investigate health-related quality of life in children with PFAPA and the impact after tonsillectomy. And what they found, something that was of course expected, is these patients before and during the episodes have a lower quality of life. It was measured by the PET quality of life. Between episodes, these patients were doing quite well and were normal, but after tonsillectomy, the level of quality of life increased for patients and also in a questionnaire for families. So the disease has a good prognosis. It's usually self-limited without sequela. The median age of spontaneous resolution is 60 months, around 5. In our experience, is also 4.8 years. And in children with tonsillectomy is slightly better. It's around 50 months. Most patients will remit
spontaneously before puberty, usually around 7, 8 years old, but some might continue and to be symptomatic into adolescence. Some cases also can have persistent or appear in adulthood, and adult patients can experience longer and less frequent attacks. And there are a small subset of patients with onset of fever in adulthood. And that's something that has been recognized recently, mostly for some colleagues from Italy and also from one of my colleagues in Barcelona hospital. So this, for example, was presented 7 years ago, 17 adults with an average age of debut at 26 years, with clinical and analytical characteristics similar to series of children, but these patients present more arthralgia, more myalgia, more asthenia, headache, and rash, probably also because they express better than a 2 or 3 year kids old. And the majority of these patients responded also to corticotherapy. Only some of these patients went to a tonsillectomy. Comparing children with FAPA with adults with FAPA, it has also been done in the past. We saw that Aphthous Stomatitis is less frequent in adults than in children, and the recurrence are also every 4 or 6 weeks. And lately, 2 years ago, there were proposed adult FAPA criteria. As you are pediatrician, probably not so interested, they are still need to be validated. Which are our take-home message? FAPA syndrome is the most frequent periodic fever syndrome in the childhood. Is pathogenesis? It's not known, but it seems that there is an immunological alteration in patients genetically predisposed to an activity nation. A diagnosis is clinical. We have these new criteria. Differential diagnosis should be made with other causes of recurrent fever. The treatment of choice to avoid episodes are oral glucocorticoids in case resistant or with severe involvement in the dynamics of the family. You can consider tonsillectomy. There are rescue treatments like colchicine or anti-IL-1 only for very selected cases. These patients pay attention because they have a lower quality of life, the patients and their family, especially during febrile episodes. No? That's all. Thank you very much.